For those, there are people listening who names I don't recognize, so they probably don't know who Sara is. So just a word of introduction. She's not the newest, because we have two even more junior people at Northwest Asthma and Allergy, but joined Northwest Asthma and Allergy how long ago now, Sara?
In 2019, so just before the pandemic.
That's right. You were in Italy, I think, at the very
Yes.
beginning of the pandemic, and when they were having a tremendous outbreak and had a quarantine when you first came back. And you did your fellowship where?
At UCSF.
UCI, okay, San Francisco.
San Francisco.
So she has a topic, I don't know the exact title, but it basically has to do with the mechanisms of chronic urticaria, which has been renamed. We call it chronic idiopathic. Now someone has decided it's chronic spontaneous urticaria. At least that's the term I've been using when I write notes now instead of CIU, CSU. And new therapies that we may have for it in the near future. So why don't you go ahead and launch your slides?
All right. Sorry, I have like lots of things open. All right, this should be it. Can everyone see that?
Yes.
All right, sorry, I don't know why it didn't go forward. All right, well, I'm Sara, for all those people that I don't know. So we're gonna be talking about urticaria. I'm still used to calling it CIU, even though I didn't finish my training that long ago. So I kind of use CIU and CSU interchangeably throughout the presentation. So I don't have any disclosures. Move my stuff really quickly. So we're gonna go through the pathophysiology of chronic urticaria, discuss some of the main immune mediators, current treatment options, and then future treatment options. So a little bit about epidemiology. So the prevalence is thought to be about 0.5 to 5% of the general population, with incidence about 1 to 1.5% every year. So it's common in adults in the 3rd to 5th decades of life, with women more affected than men. Chronic urticaria is defined as ongoing symptoms for most days of the week lasting greater than 6 weeks. So if you're under 6 weeks, then that's when you're kind of still in the acute category. So there's quite a few different presentations. The majority, so about 50%, have an urticaria predominant phenotype. About 40% will have both urticaria and angioedema, and about 10% will have mainly angioedema. It's self-limited in most patients, with an average duration of about 2 to 5 years. And overall, active CSU significantly impairs quality of life, which is why we have these treatment options to try to control that better. So as we all know, there's some classic features of urticaria. You have this area of central swelling with the surrounding erythema. There's a couple pictures here of urticaria. As you can see on the darker skin, sometimes it can be a little bit harder to discern that kind of erythema on the skin. There's this itching sensation. The lesions by default are fleeting, so they're only lasting about 30 minutes to 24 hours. And then your skin is normal afterwards. You don't have any sort of bruising or discoloration to the skin once the urticaria lesion is gone. Then you also have angioedema, and that's episodic submucosal or subcutaneous swelling. It's asymmetric, and it affects non-dependent areas of the body, like the lips, the cheeks, periorbital areas, extremities, and genitals. It will typically develop over minutes to hours and resolves gradually over 1 to 3 days, depending on the initial severity. The areas can feel painful, numb, or have like a tingling, pruritic feeling. And then you can also have, if you have angioedema of the throat, tongue, or lips without associated urticaria, then that's when you should consider some other sort of like drug-induced angioedema or hereditary angioedema or a C1 esterase inhibitor deficiency. So there are a subset of people that can have some systemic symptoms like headaches, fatigue, pain, swelling of the joints, wheezing, flushing, GI symptoms, palpitations. In a cohort that I found, they had patients with systemic symptoms. They typically had severe or more longer lasting disease, and they had significantly higher baseline tryptase levels compared to those with without systemic symptoms. So generally, they were all kind of below the general threshold that we use as abnormal, as well as kind of the ones that are now used for alpha tryptosemia, which is more along 8. These were kind of 5.1 versus 3.9. And then because of these systemic symptoms, they had increased effects on their quality of life. And then if you ever notice kind of any associated fevers or evidence of joint inflammation, then you should do kind of more of a workup for more of an urticarial vasculitis over just standard CSU. So basically, the pathophysiology of CIU, sorry, that should say mast cells. I didn't catch that on spell check. So you have degranulation of skin mast cells. And then with the degranulation, you get the release of histamine and proteases and cytokines. Those will generate some activating factors and other arachidonic acid metabolites like PGD2, leukotriene C4, D4, and E4. Those will ultimately cause some increased vasodilation and vascular permeability, which will lead to interstitial edema and then sensory nerve stimulation, which ultimately gives you swelling, erythema, and pruritus. So this again kind of goes through, the antigen attaching to the IgE on the Fc epsilon 1 receptor of the mast cells, and then those kind of go downstream to elicit kind of various mediators, which then will kind of lead to your urticaria, and then kind of some of the direct and indirect effects that will lead to that. When you take a skin biopsy, you'll get kind of these perivascular mixed infiltrates with other cells, including basophils, C4 lymphocytes, monocytes, neutrophils, and eos. And you have increased IL-4, IL-5, interferon gamma, and of cellular mRNA expression. So now let's go through kind of a little bit more in detail, these kind of more so major players that are involved in the immune response. So the first ones are mast cells. So they're derived from CD34, CD117, and CD13 pluripotent cells. So you have two different classes. Ones are the MCT, and those ones are the tryptase positive, kinase negative, and they're T cell dependent. And those are in the intestines, the lung, and the nose. And then you have your MCTC cells, and those are in the skin and the GI tract. Those are tryptase positive, kinase positive, and those are T cell independent mast cells. The MCTC ones are the ones that make up the majority of the mast cells in both lesional and non-lesional CIU or CSU skin. So they're activated through an Ig-dependent stimulation. So you have your IgE, which is bound to your high affinity IgE receptor, which is your Fc epsilon R1. So for, the fellows, this literally is like, they ask you, like, these are one of the random questions on boards, knowing where it links. So that will cross-link, and then you get an intracellular signaling cascade, which will ultimately lead to mast cell activation and mediator release. There is also, the mast cells also express this mass-related gene X2, or MRGX2, and it's a G protein coupled receptor activated by a 4880 vasoactive intestinal polypeptide and quite a few drugs. And ultimately, that's thought to be a secondary mechanism for mast cell activation that's independent of IgE. And it's been found that it's unclear if the total number of mast cells is increased in people with CIU versus healthy controls, though it's thought that this specific population of cells, these MRGX2, are significantly increased in CIU compared to healthy controls. Moving along, then you also have your basophils. So those contain surface Fc epsilon R1 receptors that will bind IgE, and they're activated again after the IgE cross-links once binding to the surface receptors. They do not have that MRGX2. What's interesting is that patients with active CIU tend to have vasopenia, and it's thought that that happens because the basophils actually migrate from the blood into the skin, so they're not present when you're looking at them in the blood. Greater degrees of vasopenia are associated with the higher UAS score. And then typically the vasopenia will resolve with disease remission. In some post hoc analyses that they did of phase 3 Zoller studies, they found the improvement in basopenia was correlated with the clinical improvement in a dose-dependent manner. So there are some basophil functional phenotypes that are related to IgE-mediated release, IgE-mediated histamine release. So you have your CSU responders, and those are relatively similar to healthy controls. They have greater than 10% release of total histamine content with an optimal ex vivo IgE receptor activation. You have your non-responders that have less than 10% release, and then you have your non-responders who are basopenic, and those are clinically the most severely affected with the greatest propensity for autoreactivity. And ultimately, when you're in disease remission, then all of these categories go back similar to kind of the healthy controls, though they seem to have some increased sensitivity to kind of the IgE reactivity. Then you also have the eosinophils. So, you know, the significance is still unclear, but they're always around. So they're significantly increased in the skin biopsy specimens for both lesional and non-lesional sites of patients with CIU. It's hypothesized that eosinophils, along with mast cells and basophils, prime the skin for wheal formation. And it's known that both tissue factor will colocalize with the eosinophilic cationic protein. And when you activate the tissue factor, it triggers mast cells, which degranulate, and that leads to wheals. There's also a colocalization between vascular endothelial growth factor with the eosinophilic cationic protein, and that helps regulate angiogenesis and is a mediator for vascular permeability. And then eosinophil granule products are also thought to activate MRGX2, that MRGX2 receptor, so kind of an IgE independent manner of activating the mast cells. And so this is from a paper. There was quite a few kind of new review papers that were published in the last year going through kind of the different cell mediators and their roles. And so this kind of shows the role of the eosinophil and how it interacts with kind of all of the different parts of the immune system in activation and kind of inactivating these cells and causing mediator release. And again, kind of the mast cells kind of cause urticaria symptoms, and then the eosinophils can kind of indirectly also activate the mast cells, which activate other things, which will activate mast cells, and then have some mediators that lead to urticaria symptoms. There's also lymphocytes, and so biopsies will show the prominence of CD4 lymphocytes, and there's not really a lot of B cells in those biopsies. The CD4 cells have characteristics of both Th1 and Th2. And then recently it's been found that autoreactive T cells to the IgE receptor have also been found in patients with CIU. Autoimmunity also kind of plays a role. It's thought that about 30 to 50% of patients with CIU will produce IgG antibodies against the Fc epsilon R1A subunit component of the high affinity IgE receptor. And about 5 to 10% will produce IgG antibodies against IgE itself. Generally, so there is availability to look for, it's called urticaria component. We send it a lot in fellowship. You know, we called it, it's just like the Fc epsilon receptor antibody, or like the CIU test, I think is the other name. A lot of these labs, the problem is that they're non-specific, and they're also seen kind of in standard healthy controls. And so we have yet to develop any sort of standardized assays to kind of find those patients with an autoimmune component. There are also, like, people used to do, you know, you could skin test to people's own serum, and that to an extent would be more reactive in patients with CIU. I never did that in my training. It seems like, again, it's not really specific in, you know, identifying, because healthy controls can also have that. Along with that, there's kind of, you know, quite a few people with CIU have, you know, thyroid related disorders, though kind of in the practice parameters specifically, they were talking about, you know, screening for thyroid disease is generally at low yield in patients without specific thyroid related symptoms or the history of thyroid disease. Anti-thyroglobulin or anti-thyroid antibodies are present in euthyroid individuals, and it's unclear what the exact clinical implications of those are. I know just generally, if you're trying to get solar approved, there are some standardized tests that they recommend. And so I typically will send those, even though, in theory, it's unclear, if clinically you should or should not be sending labs. I know that was, a little controversial even when I was in residency too. And, did we have to do labs or not? Though it seems like most people still do. And then same thing, although the commercial test is available, the utility of testing for the autoantibodies or is kind of unclear. And it's unclear, if this is a marker of disease severity or whether this identifies a clinically unique population or whether this will actually change what you're doing when it comes to management. So generally, your kind of initial evaluation is, a lot of it is based on, history and physical exam. It's really making sure that the rashes that the person is describing are consistent with CIU, which can be tricky if they are just verbally describing them and don't have any pictures and don't have any active lesions. So typically they're, edematous, pink or red wheals. They're in variable size and shape and have the surrounding erythema. They typically fade within 24 to 48 hours. Obviously, you can have neoadhesion lesions that are appearing all over the body. I typically ask patients, like, if I were to circle the lesion, like, would it last for multiple days, or would that, would the area that you circled go back to normal? And sometimes that helps differentiate, though I feel like it's really hard without pictures or seeing it. They're generally pruritic. The angioedema associated with it is kind of non-pruritic. It's kind of this brawny, non-pitting edema without well-defined margins and no associated typically erythema around it. If patients have kind of painful lesions, that's typically not characteristic of CU, and that may identify more so a prevalence of a cutaneous vasculitis. The vasculitis lesions are typically palpable and non-blanching compared to urticaria, which is blanching. They last for multiple days in a row. And typically when they fade, they kind of almost leave like a bruising or discoloration. They don't just leave normal, regular skin behind. And though in some cases they can, represent more so CIU, we are not going to talk about that today, but I think that is an upcoming talk to get excited about. The cause of the large majority of urticaria is undetermined. And again, there's not really any diagnostic testing. You can, kind of like we briefly talked about, do some targeted laboratories based on history or physical exam, including CBC with differential, ESR-CRP, liver enzymes, or just a general like TSH and T4. And those with an unremarkable history and physical exam, again, it's really unclear whether you need to do it, though it potentially can identify some sort of infrequent or rare cause of CU. That's the manifestation of some underlying condition versus just idiopathic. And, to provide the patient some reassurance that no, indeed, we don't have a reason why this is happening. The large majority of patients that come to see us think they're having multiple allergic reactions, but skin and in vitro testing for IgE to inhalants and foods or extensive lab testing is not indicated, despite what patients may or may not desire. Kind of, again, most cases don't have an underlying cause, though if they do, you can have some IgE, more rare IgE-mediated reactions to foods or drugs or other allergens, chronic infectious processes like Hep B or C, EBV, HSV, H. pylori infections, or helminthic infections, other systemic conditions which are complement-mediated or immune-based, so kind of some of the specific complement component deficiencies, cryoglobulinemia, serum sickness, or other immune-mediated complexes, connective tissue disorders like lupus or JAA, thyroid disease, and then some neoplasms, as well as some other kind of endocrine disorders or hormonal therapies like oral contraceptives, or I know myself and I think Dan as well have seen some patients that with like hormone therapy for transitioning, which has also caused this, or higher hormone therapy for people undergoing like IVF. There's also autoimmune disorders like lupus, dermatomyositis, and polymyositis, Sjogren's, Still disease, which have been associated with CIU. Again, the serology to diagnose underlying autoimmune diseases is not warranted in the initial evaluation unless you have, some other features or concerns based on the history of the patient or family history that would warrant you to kind of do additional testing. So when it comes to treatment, there are kind of a variety of options. So the one on the left-hand side kind of goes through the Quad A guidelines from the practice parameters, which were most recently published in 2014. And then there's kind of the like World Health Organization or World Allergy Organization guidelines on the right. So, you know, avoiding of any triggers if possible. Then you start with kind of the second generation monotherapy, and then you kind of step up therapy from there. So your first step are the H1 antihistamines, and they act as a reverse agonist. They combine with and stabilize inactive conformation of the H1 receptor. What's interesting is, you know, most people come on just daily doses of antihistamines, but it's found that about 63% of those that don't respond to single dosing will respond to kind of the high dosing that we use, which is 4 times the daily dose. Then you have your second line, which is the H2 blockers, as well as your leukotriene receptor antagonist or your singular, as well as the first generation antihistamines. They had a specific subnote that was saying to consider montelukast daily as a second line agent in addition to second generation H1 blockers in the treatment of angioedema predominant CIU. And then your third line includes the addition of more potent antihistamines like doxepin or hydroxyzine. Then you start to kind of get into kind of the other therapies. So the main one that is currently used is omalizumab, which is anti-IgE. It was actually approved in 2014, which is the year that I finished med school. So it's kind of crazy that all of these are still relatively new. So it binds to the free IgE. Another random board question, it's on the C3 domain of the heavy chain. And it prevents IgE from attaching to the Fc epsilon R1 receptors on mast cells, basophils, and other cells that contain that receptor, including dendritic cells. It does not bind to surface IgE, so it can't cross-link it, and so it can't activate mast cells or basophils. And then as the free IgE decreases, it actually will make a decrease in the Fc epsilon R1 receptor due to a general decline. So there's actually kind of involute, and they decline in number due to degradation and internalization of the unoccupied receptors. So unlike the asthma dosing for Xolair, it's a fixed dosing of either 150 milligrams or 300 milligrams every 4 weeks. The majority of people that are going to respond quite quickly. Non-responsiveness is predicted by a low baseline IgE. In fellowship, we tended to check IgE a lot. Feel like I don't do it as much here. So it was interesting kind of going back and seeing, you know, kind of some of those baseline IgEs pre Xolair to see kind of some of those lower ones if they have a harder time responding. Unchanged total levels of IgE within 4 weeks of the first injection, or low baseline levels of Fc epsilon R1 receptors on basophils. For refractory patients, there are some studies that have demonstrated—
Sarah, can I ask you a question?
Yeah.
Once you start giving people Xolair, you can't really measure accurately their IgE because the bound IgE is in the circulation with the Xolair. So yeah. The second point here, unchanged levels within 4 weeks, doesn't make any sense.
I think it was more, so I don't know, I'm assuming that was more on clinical studies. They were just kind of saying that some studies have demonstrated that. I didn't elaborate more on it. It was just in one of the reviews that I was reading, that's what they were saying, how they determined unresponsive. Right. And then for refractory patients, there are some smaller studies that have demonstrated benefit. And I know I've gotten it approved for a couple patients, increasing the interval or increasing the dose. So changing your interval to every 3 weeks, trying to push it up a little bit, or increasing your dose to 450 or 600 to try to get a little bit better response. And this again is just a figure of kind of how it works and kind of all the different functions of omalizumab, including binding to the free IgE. So you decrease your cell-bound IgE, decreases the expression of the receptors, which therefore you can't cross-link, so decreases mediator relief, and then it kind of prevents this allergic inflammation. So then you have cyclosporine, and that ultimately binds to cyclosporine, which inhibits the activity of calcineurin, which the original role of that is to dephosphorylate the nuclear factor of activated T cells. So that because it's not, because it can't do that job, it remains in the cytoplasm and therefore can't go into the nucleus. And if it can't go into the nucleus, then you can't make autoinflammatory cytokines like IL-2, IL-3, IL-4, TNF alpha, and therefore you're unable to affect, so then you can't, those mediators can't affect lymphocytes, mast cells, and basophils. So I know in talking to some of the providers at NAC who use this more frequently, you kind of start around 2 to 4 mg per kg per day, and then you can kind of titrate around for effect. It has been shown to be efficacious in patients with refractory CIU, and it is capable of inducing remission, though this is from the practice parameters in 2014. So this is right after kind of Xolair was also approved. They kind of talk into, they say there are some study limitations and potential harms, associated with cyclosporine. And so their recommendation was more of a weak recommendation versus a stronger recommendation for Xolair for the use of CIU, though I know we, still do use it because our options are limited. And so for some patients, particularly those with more of an autoimmune component, it can be, useful. And then I found some really good reviews on kind of some of the emerging therapeutics. So this chart, kind of the ones that are highlighted in red are kind of all of the different newer drugs that are coming out and where they affect the process of development of urticaria. And we're going to kind of talk about them more kind of individually in detail. So kind of the first step are drugs that are already licensed. So they're already approved for other indications, but they may have a role in CIU. So the first ones are the IL-5 monoclonal antibodies. So mepolizumab, resilizumab, and then benralizumab, which attaches to the IL-5 receptor. So mast cells will ultimately recruit eosinophils by releasing IL-5 and other chemotactic mediators. And since kind of we talked about before, eosinophils it's not exactly clear what their role is, but they do have a role in, mediating CIU, and the blood eosinophil, like high blood eosinophilia, is linked to, high disease activity and poor treatment response. So there are clinical trials now looking at the use of some of these, including benralizumab and mepolizumab, specifically in CIU or CSU. I don't know if any of the reps are on to comment more specifically about those studies. In the review that I found, they had all the clinical trial kind of, studies listed. I couldn't find any released information as of now. I don't know if that's correct or not, if anyone has any additional information on those ones specifically that they would want to comment on or not. All right, so then the other one is dupilumab or Dupixent, which is anti-IL-4/13. It blocks the shared IL-4 alpha receptor subunit. IL-4, IL-13 contribute to Th2 class Th2 immune response through T cell differentiation and IgE class switching. There's been small studies in patients that have been refractory to omalizumab that have responded to Dupixent. And again, there's current ongoing studies looking at 600 milligram loading dose with the 300 milligrams every 2 weeks for 16 weeks of Dupixent specifically for CIU. Then there's kind of more of the room E drugs. So you have your TNF alpha inhibitors like adalimumab, etanercept, and infliximab. So those will activate mast cell production. Activated mast cells produce pro-inflammatory mediators, and TNF alpha is one of those pro-inflammatory mediators. And it's upregulated in the skin and serum of patients with CIU. And so there's been smaller studies, there's no large randomized control studies, which have shown that either combinations, like this one had 25 patients and 15 had complete response after treatment with adalimumab and etanercept, some of whom were actually refractory to Xolair. And then there was a really small case of 6 patients treated with one of them. Any of them were used, and they had complete remission or partial improvement, which actually lasted several years afterwards. You have your anti-CD20, which is rituximab, and it binds on the CD20 of B cells, and it may inhibit production of functional IgG autoantibodies against Fc epsilon R1 or IgE via depletion of memory B cells. And there's been some small studies that show an effect. However, there was one RTC and it was actually stopped due to safety concerns associated with rituximab, so may not be a great option, but it has been shown to potentially be effective. Then you have your IL-1s, which are anakinra, canakinumab, and rilonacept. And so IL-1 is linked to the development of wheals in patients with autoinflammatory diseases and syndromes, so kind of some of those familiar cold urticaria syndromes. And they will respond to IL-1 targeted therapies. So anakinra has been shown to be to improve refractory delayed pressure in cold-induced urticaria. Canakinumab has been very useful in urticaria vasculitis. The clinical trials for those are still pending. Then you also have T-cell co-stimulation molecules like abatacept, and it will link extracellular domains of human cytotoxic T lymphocytes, associated antigen 4, to modified FC portion of the human IgG1. And so there's been small studies of antihistamine resistant CIU with evidence of underlying autoimmunity that showed that 3 of the 4 had a complete response, complete resolution of CIU within 3 months of their abatacept infusion. There's also tranexamic acid. So there's also some component of the coagulation cascade, which is seen in CIU. They've shown that blood markers of thrombin generation, fibrinolysis, and inflammation like D-dimers are elevated in patients with CIU, and it potentially can correlate with disease activity in response to treatment, though it's been unclear in the trials that have been done with this whether you actually get an improvement over placebo. And then IVIG can be effective in patients with severe and therapy-resistant CIU, though there's no trials that have been done yet.
Sarah, have the studies with the already licensed biologics had control groups?
I believe I'm actually not sure. I would need to look up the trials. I don't know if anyone has any specific information on those or not. I have the clinical trial like IDs, so I could look it up, or I can send you. There's some really great reviews that were published, one in the annal, both of them in the annals, that kind of list all the ongoing clinical trials and all the trials that have actually been related to all of these medicines as well. Anything else?
Well, it just seems to me that the logic of using some of those drugs is contorted as far as mechanistic reasons that they should work, and really to believe they work, you need a control group.
Yeah, I mean, those
the disease is too unpredictable to say that anything works unless you have a control group.
Yeah, I mean, they were just kind of highlighting some of the smaller published studies, but again, the clinical trials are ongoing, and my assumption would be if it's a clinical trial that there's some specific group that is the control, or compared to Xolair or something that you're comparing these people to. This was just again mentioning these are licensed medicines, so they're already approved, just not for the indication of CIU, and some people have found an effect with them. Yeah, let me see. Yeah, so there's like a whole trial. Unfortunately, the paper, I can't pull it up on my computer. If not, I would share that screen because I don't have library access unless I'm logged into Children's, so it makes it a little tricky. I don't have the paper pulled up right now. But the paper itself is called New Treatments for Chronic Urticaria, and it was a review in the Annals published last year. And it says for like Dupixent at least, there's 2 phase 2A randomized control studies, and then they're in Germany, and they were multi-center studies. For MEPO, it was an open label single arm exploratory study that was in the US. For benralizumab, it was a non-randomized single blind study in the US. Those are and then I have there's like the clinical identifier on
That's okay. Go ahead and move on. That's all right.
So then you have drugs that are in development. I think one of the most promising ones is legalizumab. which is a humanized monoclonal anti-IgE antibody. However, compared to omalizumab, it has a 40 to 50-fold greater affinity for IgE. And they did do an RTC with omalizumab versus placebo versus ligelizumab in various doses for 20 weeks. And ligelizumab demonstrated rapid onset of action. It had a dose dependent, so depending on what dose they chose, suppression of free IgE, basal, Fc epsilon R1 receptors, and basophil surface IgE, and was just generally superior to omalizumab. So greater than 50% of patients that were on the highest dose, which is 240 milligrams, were complete responders. In the meantime, to relapse after discontinuation was 10 weeks for ligelizumab compared to 4 weeks with placebo, 4 weeks with Xolair. Dan Petroni has a patient that that was quite refractory, that he was able to get approved for or get started on this. I don't know if he's on or not or wants to comment further, but I believe his patient had a pretty good response, despite being refractory to most things, had a really good response to ligelizumab. And then there's UB211, which again is another humanized monoclonal anti-IgE antibody. That one is said to have an 8-fold higher binding affinity to free IgE, and then it downregulates compared to Xolair, and it downregulates the synthesis by binding on the CD23 of IgE.
As far as ligelizumab, you probably know Dan Petroni has gotten the drug for sort of compassionate use in some very recalcitrant people. Someone who failed the combination of cyclosporine and omalizumab and has done very well on ligelizumab. I mean, that clearly looks like the most promising drug in development.
Yes. I don't know if he's on to comment any further, but I remember him saying his patient was quite refractory, was having a lot of issues, and they had a lot of success on it. Then there's AK002, which is a monoclonal antibody against Cyclic 8. And we had a talk last year about Cyclic 8, and I think its role in multiple eosinophilic diseases is being looked at. So Cyclic 8 is an inhibitory receptor of CD33 related family of salicylic acid binding immunoglobulin-like lectins. It's uniquely expressed on the surface of mast cells, eosinophils, and basophils. And with the binding on eosinophils, then you get caspase-3 or reactive oxygen species dependent cell apoptosis. And so it inhibits mast cell activity, it depletes EOs, and it significantly inhibits Fc epsilon R1 dependent histamine and PGG, prostaglandin D2 release. In some of the studies, it's been shown to deplete EOs within an hour. And then depending on the dose that you're using, you can have an extended duration of depletion, which can peak up to at about 40 to 84 days. So it can be quite effective and can last quite a while. So there's been some small studies that demonstrate, so one had 13 patients. So 12 of the 13 who were antihistamine resistant omalizumab naive had a complete response within 22 weeks, and then 6 of the 11 antihistamine and omalizumab resistant patients had either complete or partial response by week 22. There's also AZD1981, which is a CRTH2 antagonist. So CRTH2 is expressed on basophils, eosinophils, some Th2 cells, and type 2 innate lymphoid cells. And then PGD2 is a product of activated mast cells, and it induces chemotaxis of eosinophils and basophils via that CRTH2 receptor. And so expression of this is decreased on basophils and eosinophils in CIU, and it's thought to be secondary to this in vivo PGD2 activation. There's also fenebrutinib or LOU and LOU064, and those are BTK inhibitors. There is an approved one called brutinib. For that is an approved one, though the side effect profile is too strong because it's a global inhibitor of BTK, and so that one is not being considered. However, these ones are very specific. So they're highly selective, reversible, non-covalent, and it's an oral medication. BTK is an enzyme that's involved in signal transduction downstream from Fc epsilon R1 and the B cell receptor. And so it's essential for Fc epsilon R1 mediated mast cell activation, as well as the maturation and function of B cells. So ultimately, you're inhibiting IgE and mast cell mediated responses. But again, the available ones, like they've been shown to be effective. And I want to say Jen Regan, who's probably not on, but I think her PhD or some of her PhD was related to BTK studying in allergic patients. I don't know if anyone knows more about that, but I'm pretty sure at one of the quad AIs they were talking about it, and it was one of Jen's paper that she had published. And then you have GSK 264-62464, which is a topical SYK inhibitor. So spleen tyrosine kinase, or SYK, is a member of the non-receptor or cytosolic tyrosine kinases, and it's involved in signal transduction in B lymphocytes, mast cells, and macrophages. And it's an integral component to the intracellular Fc epsilon R1 signaling cascade, which induces mast cell degranulation when that cascade is activated. And so in vitro studies have demonstrated reduction in SYK phosphorylation and downstream signal transduction in IgE sensitized mast cells after treatment with omalizumab. And so this medication, it's a small molecule SYK inhibitor, and it will absorb through the skin. And so it's applied topically, and it inhibits anti-IgE histamine release by the human skin mast cells in situ. So that's another one that's undergoing clinical trial.
Sarah, on that last one there, it's a classic paper from years ago saying that, and you didn't touch on it, that one of the mechanisms of chronic urticaria is an imbalance between SYK and SHIP, the phosphatase in cells. And so at least if there's an alternative hypothesis to the autoimmune hypothesis of chronic urticaria. And I think that there's good data that that's true. So you would think that maybe that last molecule would be promising.
Yeah. So there's ongoing kind of trials or looking into, and then, the thought is the more we understand the pathogenesis of, what's going on in CIU, then the more you can find, specific medications that are targeted against those various effects or those various receptors to inhibit the hives or the signaling cascade, which causes the hives and the swelling. And so, as you can see here, again, this is the paper, and it kind of is highlighting all of these different medications and their role and how they may play a role in the development of urticaria. So that's all I have. The word of the day is hives. So 15 or so minutes to spare. I don't know if anyone else has any other questions. I can send out the updated slides. And then here are kind of some of the papers which are kind of going through both the cells that are in the responses as well as some of the new and emerging treatments. And those have all been published either, I think the latest one was 2019, but most of them were published in 2020 or even this year going through that. So there's a lot of exciting work being done in this, and hopefully we'll have some new approved medicines soon for patients that we can't get controlled on Xolair or Cyclosporine.
We have some questions. We have a big audience, over 40 people. One comment I'll make from treating a lot of these people over a long time is it's one thing to write guidelines that you increase non-sedating antihistamines fourfold, and then you add montelukast, and then you add H2 blockers. By the time most people get to us, they are frustrated with this problem. And I personally have never found montelukast helps, that H2 blockers help. And by the time you've quadrupled their antihistamines and they've failed, they want this disease resolved. And the two things we have right now that work are cyclosporine and omalizumab. And I move right to those drugs because you can go to a primary care doctor and be told to take more antihistamine. That's not what these people are looking for. So I mean, that's been my strategy to get people improved and into remission, and they find that as a blessing because this is a very uncomfortable disease. I mean, people have equated the discomfort similar to angina to live with chronic itching in your skin.
Yeah, yes, it has a really big impact on quality of life. And then kind of compounded on that, things like anxiety and stress can make hives worse, but then, it adds a great deal of that to your life. And so, yes, the quality of life is kind of one of the bigger things that.
Paul made a comment here online. That's why the European guidelines don't recommend montelukast. And I don't know about the rest of you, but the only reason I use it is that insurance companies, set their own guidelines before they'll approve omalizumab. They want to see a month's failure. I think that's mean and cruel. These guidelines that they set, you have to fail X, Y, and Z for a month. These people have been failing for many months by the time they come to us.
Yes. Yeah, or they've just gotten a lot of courses of prednisone from urgent care, but are never started on.
Right, which is not the right approach. Well, there must be more comments out there. We have a lot of people listening to you.
I'll ask a question, Sara. I'm just curious if, I think it is relatively true that response to omalizumab partially relates to IgE level, which makes sense given how it works. But I think we've all seen excellent responses, people with hives for 20 years after a dose or two of omalizumab that have normal IgE. And I'm just curious if you've come across any mechanistic studies in those patients. How does it work? Does it somehow downregulate mediator release from mast cells in the absence even of IgE being elevated?
That is a great question. Let me see. I can't think of anything I didn't look at anything off the top of my head, but let me see if I can find the paper specifically that was kind of mentioning that.
I mean, in clinical practice, Frank, most of us, we never measure the IgE.
No, that's
no
why
use
I'm
to us. Yeah.
curious.
I didn't, so I have a unpublished paper because I never got around to publishing it at the end of fellowship, where we kind of looked at people who, like, how they weaned Xolair and just the general, like how long they were, if they like weaned Xolair versus just stopped Xolair cold turkey, and what ended up happening to them in like a cohort that we had at UCSF. And there it was pretty routine. We did a lot of labs at UCSF. I think just that's like academic center type thing. And so IgE was one of the standard ones that we did. And so a lot of people did have normal levels, but then it was like, low normal versus like higher, because your range is still, pretty broad. I can send you that specific paper where they talked about
I would just
I'll have to pull it up to see specifically if they say why, even in, because I think a lot of these, it's not necessarily that they've elevated IgE, it's just like higher versus like an IgE of like 2.
Yeah, and it makes sense in some of the, even though they may not have a lot of, receptors on mast cells, if their IgE is lower, it's going to eliminate some of the targets for some of these patients. So that makes sense.
Involution too, like it causing the like Fc receptors to down, so then there's just nowhere to bind.
Yeah. Well, just to quote patients, like, I don't care how it works, just keep up with the infusions.
And I think with Xolair in general, it seems like it's like, I don't think anyone knows why Xolair in particular works as well as it does compared to other medicines that have come along. Ligelizumab obviously is quite effective, but I think that was, I feel like at least personally, I use Xolair much more, now, like, I mean, almost exclusively for hives over asthma in a
Right.
large majority of patients.
Yeah, I'd have to say probably 90% of our patients, that's the case,
Yeah.
or why they're on omalizumab.
This is Vinod Doris, I'm one of the practicing allergists. Can you hear me okay?
Yeah.
Yeah, great. Thanks for the wonderful talk. I had, just one comment or one thought on Frank's, IgE level or IG level. I think, as good as IgE, a total IgE is a marker for, an allergy, we do know a lot of patients who probably are allergic and have really low IgE. And, quite always, it's not a good marker to say that there's not a problem going on over there. It's just one observation. I think we do see people who have low IG in the single digits who are atopic when you kind of do skin testing and they're allergic, right? So that's one. The second part is, in terms of guidelines with lens, I think guidelines are good, but in living in Seattle, one of the things, is if you have some, quite often when with chronic hives, the patient's coming there, I want to treat the cause, I want to treat what's happening to me. And quite often it's like, I think it's something in my diet, it's something I'm eating. And of course, guess what they do? They come and see you, and the thing they do is if you don't have the right solution, if you can't take care of them, is they're gonna get all the good food sensory testing that's out there. They go on the low histamine, kind of restricted diets, and quite often, from the allergy perspective, we need good approaches. At least omalizumab and cyclosporine, the only two that we have successfully that we can use right now, but it's something that can actually treat the problem, right? So I think otherwise, they go onto all these restricted diets that's probably more problematic and, more life restricting. Thank you.
I mean, that's a good point. That's why I think getting on with effective therapy rapidly is important before they get IgG food testing and go to naturopaths and have other bogus and invalid testing and waste their time and money. Because that's true, Vinod, that these people obviously want a specific explanation and often think they have food allergy, and as we all know, come in with a list of nonsensical things that they think are provoking the problem.
Yeah, I agree with that. I just try to counsel as much as I can. Like, you're waking up in the middle of the night with hives, like it's not something that you ate 7 hours before. You're waking up in the morning with hives. It's not something that you haven't eaten for 8 to 10 hours. Unlikely that it's anything that you ate that night. But yeah, I mean it's frustrating. It's so upsetting because you see hives and you think, and they're told when they go to urgent care, the emergency room, everyone's always told when you have hives, like you're having an allergic reaction. So then your natural inclination is to think, well, I'm having an allergic reaction. What am I allergic to? Versus people describing like you might just have chronic hives or an episode of acute hives, but not caused by anything that you're doing, but just internally. And for most people, it's frustrating, but we don't know why.
What I do that I think helps with that explanation, these people are all dermatographic. And if you stroke their skin and you show them their dermatographic, visibly right on their skin, you say to them, listen, you didn't just eat the food you think provoked the problem. You didn't do X, Y, or Z. I can make your hive, right now, right here. And most people get it then, that this is an inherent quality of their skin driven by immune mechanisms internally, and there is no single external trigger for this. That helps me a lot in explaining it to people.
Hi, Sarah, it's Paul McBride. I just have a question about the anti-Siglic 8 antibody. That is going to be coming into our lives in a big way with eosinophilic esophagitis. So it's fascinating that that works for this as well. So can you comment a little bit more about that?
I mean, so they kind of just commented generally, but it's the fact that it depletes the eosinophils so effectively. And the thought is since eosinophils, and there's a whole review on kind of the role of eosinophils in CIU, and I think it's still unclear exactly. They're always there, and it's unclear. Like they are they're recruited by the mast cells, and then they have downstream effects, and then kind of that specific receptor that I talked about, or that specific kind of way to independently activate mast cells. So the eosinophil cationic protein can kind of independently activate mast cells, like independent of IgE. And so the thought is removing all the eosinophils, you're kind of removing that. The paper that's really great is, so it's actually called The Role of Eosinophils in Chronic Spontaneous Urticaria. And so it's like, I mean, they kind of still leave it vague, like we don't exactly know, but it goes through kind of all the different ways in which there's evidence for eosinophils being kind of a primary driver or kind of having a crucial role in ultimately the development of hives.
Well, I agree with you. I'm struck that drug is going to be a powerhouse drug in almost all the diseases we treat. I'd buy stock in that company.
Well, that might be a good idea anyway,
Yeah.
but it's just fascinating how that the anti-eosinophil drug is going to have such a crucial role. I mean, they're not even talking about it, what it's going to do for asthma. So I don't know where
The
this
guy
drug's
who's
going
with
to end.
that company is a speaker later in the year. Amal,
Uh-huh.
what's the name of the company that?
Alicos.
Yeah, Alicos. It looks like that's going to be a very promising drug, and he's
Sorry, excuse me. Coming good through. Thank you.
yeah, he's going to be speaking later in the year about the drug. I think in eosinophilic GI disease, what we can remember to ask him about is its use in urticaria.
Yeah. Yeah, and I can send you, Paul, if you want that review, I can send you that. It was in Jackie in June of 2020. And it literally kind of just goes through all the ways. I mean, it's again unclear, but it goes through all the ways in which it's been linked to CIU. But yes, the cyclic 8 is just being used in a lot of eosinophilic diseases. It's being looked at with how quickly it depletes the eosinophils in some of these.
I just have one other sort of frustrating question is, do you have any advice on how to get these drugs approved by insurance companies? I just found out how to get dupilumab approved for nasal polyps. You have to say that the nasal polyps are bilateral and below the level of the inferior turbinate. And they'll almost always approve it for sinus disease if you give them that ringer. So I just wondered if you have any hints on how to get it for hives.
Oh, dupilumab.
Any of them. It doesn't matter which
like
one.
the times that I've tried to use. So, I mean, for Xolair, I just write down in my note that I recommend all the general things, and I do the labs that a lot of the insurance companies want, and I tell them to come back and see me in 2 weeks if they're not better, and then we can say that they've failed the therapy, and I've never had an issue with getting Xolair approved in that setting. I think for some of the other medicines to try them, you just use one of the other processes in which it's approved. So if they have eczema or they have asthma or they have nasal polyps, like the dosing is relatively comparable. And so you get it approved for that with the off chance that they're going to get the added benefit the same way that my atopic dermatitis or someone that has asthma but also has ED, they're going to get the added benefit of, that, or if they have nasal polyps but also have asthma, then I put on it for the nasal polyps, will they get the added benefit of the asthma improvement with the Dupixent. Dan Petroni would be the one that you would have to comment. You would have to reach out specifically for legalizumab because he went through, I don't know, Frank, if you know exactly how he went through, but I know he had gone through talking to the, I think FDA or through the clinical trial people, and they gave him the drug, even though the patient was, I don't think he enrolled the patient in the clinical trial. I think he just got the drug.
Yeah, he got it. He has it patient by patient. So yeah,
it's about a 4-month process, Paul, for that. It involves IRBs,
right?
Writing to the FDA, et cetera, et cetera. So I commend his relentlessness. But the answer, Paul, I think is slightly, just from working with our in-house coordinator, it's slightly insurance specific, like what hoops, which Paul and Sara have, and we all know this, on this insurance, you have to fail H2 blockers. And so you sort of learn that you just need to do that for a month or whatever and say, no, it's no better. And then, you can often get conditional approval.
And then I've had success for, this is off-label-ish, but for some patients, maybe if they're having some breakthrough, I'll be since our patients schedule their own Xolair, I just have them come in 3 weeks instead of 4 and just have them try it for, just doing it kind of without going through the insurance company. And then if they do have an effect, then I've been successful in getting a prior auth approved for at least, 4 months or 6 months. But if they try to change the frequency and they don't have an improvement, it's a lot easier just to then go back to 4 weeks if they didn't know just an improvement in 3 weeks versus trying to get it approved beforehand, because that's going to just might as well try it and then ask for permission later is what I've done for some patients, because then they're feeling better and then you have more of a ground to stand on for the insurance company. And if they don't feel better, then you don't waste all that time trying to go through it to get it denied when you finally get approved like 4 months later, it's not effective.
Well,
Well,
Sarah, you're
this is
obviously,
one reason I use a lot of cyclosporine, because I don't need anybody's approval. You just write a prescription and the drug gets filled and it works about 80% of the time. And you don't have to deal with any of this crap.
Sarah, you're obviously wise beyond your years. There's one other question. There's a little bit of literature on using the drugs for ADHD for chronic urticaria. And I've had some success with Adderall and Concerta in people their insurance won't cover anything else. And I don't know, my statistics are pretty small, but I'm 4 for 4 for people with chronic urticaria
Good
that
morning.
respond to
Oh my gosh.
Adderall and
You're tag teaming
Concerta.
over here.
Oh, I did not. I will have to look that up and see if there's anything on there. I feel like compared to other places, there's not. I mean, that would be interesting just like anecdotally from, I feel like I don't have that many ADHD patients. I feel like in some other places you have a lot more. I feel like a lot of people here on other medicines, but not for ADHD. But that's really interesting. I haven't tried that, but that's an interesting thought.
I just was curious because they all got rejected for all the biologics and then they ended up on this and they all got better.
The only hard thing is you still have to write, at least in my, with peds, we would have to you have to write the because it's can't you only do so many months and it's because it's controlled.
I haven't gotten there yet. I just got them off their steroids. So that was my only hope. But I just wondered if you ran across any of that literature because it seemed very odd to me.
I did not look at anything, at least in the, handful of reviews that I was looking at. They were kind of talking about more of the biologics or kind of those mechanisms. They didn't. I would have to actually look up the specific mechanism of the ADHD medicines if there's any sort of then relationship with the processes in CIU.
Okay, well now you've become the expert on hives, so I figured I'd just ask you while I had you online.
All right, Sarah, thanks very much. We'll end today's session. Very thorough, good discussion.
Great. I'll send out those updated slides so that they can send those out. And that way, all the kind of current reviews that I looked at are all cited on there.
Thanks, Sarah. And I look forward to when we can do this in person again.
Yes. All right. And then,
Right.
Drew, if you want to just shoot me an email, then I'll talk to you.
Will do.
Thank you. Bye.